Great hospital care not only involves necessary diagnostic testing, but also not performing inappropriate and unnecessary tests. A recent study ranked Norwalk Hospital as the best in Connecticut for avoiding the overuse of unnecessary tests and procedures. On next week's Health Talk, Dr. Jason Orlinick, Norwalk Hospital's Vice President of Medical Affairs and Chairman of the Department of Medicine, will join me to discuss this important study and its implications for patients. Hello, I'm Dr. Eric Mazer. Although many medical procedures are necessary, today we're going to discuss tests and procedures that may not be necessary, i.e. those that should be questioned and potentially discussed with patients. My guest today is Dr. Jason Orlinick, Vice President of Medical Affairs at Norwalk Hospital, and he's the Chairman of the Department of Medicine also at Norwalk. Jason, welcome to the show.
Thanks, Eric.
You know, I think when patients come to the hospital, they come to the emergency room, they go see their doctor, they expect testing. And a lot of times they're not satisfied unless they get testing. Why is unnecessary testing not good? If it makes somebody feel better or rules out cancer when you don't think it's there, why is it? What's wrong with unnecessary testing?
So before I get to that, I will confirm that is a common myth, that more testing is better. You know, my parents are getting older, and when I speak to them on a regular basis, you know, they routinely tell me, Dr. So-and-so is great because he did a lot of tests, or, right. You know, whenever I see my doctor, she always checks everything out. And I think people tend to equate that with quality of care. And, you know, testing is important when it's appropriate, but when it's not appropriate, it can create some unnecessary or undesirable effects. That's it.
Yes, I think people don't realize that, but what kind of bad effects can you have by testing? How can it possibly hurt you? That's a rhetorical question, but
sure. So there are things called incidentalomas, right? So we talk about that with respect to imaging modalities. So when you go for a diagnostic study like a CAT scan or an X-ray, you find things that oftentimes, overwhelmingly, are not important. But once you see them, you're obliged to follow them up. And so testing begets testing.
Well, let me ask you a question about that. I know the answer to this, but I want you to say it. You find something like a small mass in the kidney, and you feel therefore you have to biopsy that mass. One of 100 times it's cancer, 99 times it's benign. What's wrong? You've saved one person with cancer. Why is that bad?
Right. Well, in a lot of populations, especially older patients, a lot of these cancers or a lot of these growths, even though they're not totally benign, they're very slow growing. So we know that for certain types of lung cancers, let's say, in people who are octogenarians, thyroid nodules that turn out when they biopsy it to be cancerous. And so there's not much added benefit. It creates a lot of angst for people. It adds cost to the overall cost of healthcare, and there are complications. Every time you have to go in and biopsy things, and the treatments obviously can be pretty toxic sometimes. And so, you know, there is an element of unnecessary treatments that you will see. Having said that, occasionally, you know, you'll hear the story of somebody who just incidentally came in for chest pain, got a CAT scan, and they found a lung nodule that was cancer, and they're in their 40s or 50s. And you know, you think, wow, how lucky did I get? And we've all seen that and heard that. And so, you know, there's a balance, though, between, you know, how much you test. There are clearly things, though, that you shouldn't do, right? And so that's what some of the recent findings from the Lown Institute demonstrated. So they looked at 12 or 13 different types of tests that are commonly done in hospitals for indications that we know there's not a lot of data for. So, for example, we see a lot of patients who come in and they pass out at home. And historically, many years ago, it was very common to do ultrasounds of the neck or to image the carotid arteries.
Right, because the carotids feed the brain, and they were looking for atherosclerosis in the carotid artery as a cause of that fainting.
Right. Now, if you came in with a stroke, that's routine and standard, is to image the carotid arteries to make sure there isn't a source for, you know, a blood clot or a plaque to break off and cause a stroke. But for passing out, we know that the blockage of an artery or atherosclerosis of the neck very, very rarely causes people to pass out, and they pass out for other reasons. The most common being vasovagal episodes. Other times it can
Sort of
be
the
cardiac
common
related.
faints. You see something
Sure.
that upsets you. You feel really hot standing in a line,
Right, you
waiting
see-
for the ride at Disney World. Those kinds of things.
Yeah, you see blood and you pass out, right? I mean, we know people who are like that. They can't stand the sight of blood. In those kinds of patients, there's actually very little that needs to be done, right? Unless you find something on your examination or on your routine test that you do, like an EKG or maybe an ultrasound of the heart. If everything looks normal, there's not much more that you need to do. But to go ahead and to image the neck doesn't make a lot of sense. And if you find something, then you don't know what to do with it necessarily, because there isn't a lot of support to do anything with that.
And my understanding of that is early atherosclerosis, asymptomatic atherosclerosis here. There's no evidence of treating it early other than managing cholesterol and blood pressure, which we should do anyway.
Correct.
Makes a difference.
Correct. Yeah, absolutely. And so, the Lown Institute started looking at this. They published a paper in JAMA within the past couple of years, and they looked at these indicators, of utilization. They looked at a variety of different hospitals across the country, over 3,000 hospitals. It was a claims-based analysis, so they looked at billing data. And it gives them the power to look at a lot of different patients that were discharged from hospitals. And when they looked at the different states, in Connecticut, we actually wound up being a relatively low utilizer.
As a state?
As a state, yes, but also we were the best in Connecticut.
Here in Norwalk.
At Norwalk, yeah. Actually, the South is actually the highest utilization, and we've heard that before for those who've read Atul Gawande's books. A lot of the states where they have found over time high utilization rates has been in the South.
Yeah, I certainly have seen a lot of, where there's a lot of for-profit private medicine, you often see that kind of pattern. And I don't think it's as deliberate as it's just almost habitual, but it does, profit motives does drive some testing.
Right, so the for-profits were definitely higher utilizers and the nonprofits lower utilizers. Interestingly, major teaching hospitals were lower utilizers. And I think
that is interesting because we've always talked about residents being high utilizers.
Right. I think it probably relates to the academic environment, and I think when you're in that kind of milieu, when you're in that environment, you have the opportunity to teach your residents the correct way to practice medicine, and that's one of the things that we've done here at Norwalk. Is we've really tried to bring it to the developing physicians, the young physicians, that these are the right things to image for, these are the right things to test for, these are the things that maybe you want to pass on.
Of course, we don't mean to say that there's never an indication for a carotid ultrasound. It's really just certain circumstances where it's got a low yield. Right.
So my radiology friends or my vascular surgery friends would argue that there are obviously many indications to do the imaging studies. It goes beyond ultrasound. There are CAT scans and MRIs that you can do as well. But yeah, there are clearly indications for doing that. But certain things like passing out, what we call syncope, is not one of them.
Can you give some other examples of unnecessary tests and procedures? Again, none of these are unnecessary, are always unnecessary.
Sure.
They're just unnecessary in certain clinical circumstances.
Right.
Yeah, can you give some other examples of those?
Sure. So EEGs, these are electroencephalograms.
Yeah, that's the brainwave test.
Right, the brainwave test that the neurologists usually order for things like headache or syncope, not indicated. But we see them occasionally. We do our best not to do them. We discourage utilization of them here. I can't remember the last time we've actually done one for just a routine headache unless somebody had some neurological symptoms. But those are good examples. The other examples would be daily lab tests. So for example, if somebody comes into the hospital, do you really need to get routine labs on them every day? So we had an initiative about that about 5 to 7 years ago that we were very successful with. MRIs, so magnetic resonance imaging of the lumbar spine, of the spine for low back pain. So if you don't have neurological symptoms, usually you want to give people a trial of physical therapy and maybe some conservative therapy before you go right to doing an MRI. So those are the kinds of things that we're talking about.
How do we present this to patients in a way that it doesn't distress them? Particularly back pain. I think.
Sure.
I think almost everybody who has back pain expects to get an MRI.
Sure. I think a lot of it is time intensive. It's conversations. It's things in medicine that we oftentimes don't feel like we have the time, the energy, the skill, the desire to do, is really to sit down and explain to somebody why you're making the decision that you're making. And trying to break that cycle that more is better. because it really isn't always better.
As you mentioned, a lot of times you pick up then things that either cause distress to the patient or that for medical legal reasons you've got to pursue further.
Right.
It puts you in a conundrum that you shouldn't be in.
Right. I mean, you know, and just to be fair, I mean, there is cost to consider too. You know, the U.S. healthcare system is more expensive than pretty much any other comparator nation, you know, you can look at. If you look at a lot of the European nations or Canada, we spend way more.
Yeah, as I recall, we were twice more than anybody else in the world last time I looked at it.
Yeah, I mean, the United Kingdom, for example, my latest recollection is they spend somewhere between 10 and 12% of their GDP on healthcare. In the United States, we spend over 18% of our GDP, and the outcomes are not any better in the United States. You know, you hear about access issues, and certainly I think that that's valid. The other thing is that certain types of tests, there are downsides, like CAT scans have a lot of radiation. And so do you really want to be getting a CAT scan routinely for something that you don't need? And I would argue no, you probably don't. Yeah,
because we we have to, that's a real issue, is excessive radiation from series of tests. Now we do low dose CAT scans for patients at risk of lung cancer. That's been it's not a debate anymore, there are good studies about that, but that was an area for a long time that we didn't know what to do, and you came up with a lot of false positives. How are we dealing with all that now?
So again, there are people who really specialize in this, and there are certain recommendations of who should actually get it, right? So obviously, if you have somebody who's got a robust smoking history, they would recommend that you get it. But if you don't meet those strict criteria, then you really shouldn't be recommending it just for the general population.
Could you say, I don't want to get too complicated, but something about pretest probability? Because I know that really does help to dictate which tests we do and which we shouldn't be doing.
So your risk factors, whether, let's say, for example, if you're looking for lung cancer, so if you're thinking about a disease like lung cancer, what you really want to know is what is this individual patient's risk, going into that test. We use risk calculators now more frequently. So for example, statin therapy, whether or not you put somebody on one of these cholesterol-lowering drugs, it really depends on how old they are, how many years you expect them to live, and what their other risk factors are, because that dictates what the likelihood is that they're going to have a major cardiovascular event. And only when you reach a certain threshold, like 7.5% or 10% over the next X number of years, would you recommend putting somebody on a cholesterol-lowering drug, because there are downsides to putting somebody on a new medication. There's a cost associated with it, but there are also side effects from all medications. And so we don't just recommend that everybody go on a statin like it's in the water.
Yeah, and we can certainly emphasize side effects may even be go as far as fatalities.
Sure.
I mean, we had a doctor here who had a prostate biopsy, one that was necessary, but he had the biopsy was negative, but he developed sepsis.
Sure.
And his life was threatened. Sepsis is bacteria in the bloodstream, blood poisoning. So these procedures to evaluate something are not necessarily benign. They may be costly, they may be painful, but they can also be life-threatening, as I said.
And even in the most expert of hands, we know that any given procedure has, that has known complications, will have a complication rate. So for example, if somebody's being screened for lung cancer and you find something and you want to biopsy it, you've got multiple options. One option, and probably the most common option, is to do a needle biopsy. And usually that's done by an interventional radiologist under CAT scan guidance, for example.
We're running out of time, so just
that's a real concern, because you're sticking a needle into somebody's chest,
and it's never benign.
Right, and it's never benign, and you can bring down somebody's lung, and that leads to complication after complication.
So doing tests is not always the right thing, and we have to balance the risks of doing the test and finding something that we need to pursue versus missing a diagnosis. So it's always a balancing act when you're doing this, and I think that's really been a challenge. Congratulations to you for doing so successfully here in Norwalk. Unfortunately, we have run out of time. I really want to thank my guest today, Dr. Jason Orlinick, for joining me on Health Talk, and thank you for watching. Please share your questions and comments with us at healthtalk@newvancehealth.org. We'd love to hear from you. And again, your doctor's going to try to help you make the decisions about balancing risks and benefits with testing and treatments.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
Did you know that inappropriate medical testing not only wastes money, but also can result in avoidable risk for patients? In a recent study, Norwalk Hospital was ranked as the best in Connecticut for avoiding the overuse of unnecessary tests and procedures. Our guest on this week's Health Talk, Dr. Jason Orlinick, will discuss some of the initiatives responsible for this success. These include support from the teaching faculty in lecturing medical residents on this topic and their role in supervising the residents in patient care. So don't go away, Health Talk is up next. We've got Dr. Jason Orlinick here, again, Vice President of Medical Affairs at Norwalk Hospital and Chairman of Medicine at the hospital. Jason, you've actually made a deliberate effort in the department to reduce the use of inappropriate and unnecessary testing. First of all, how do you go about deciding what's inappropriate and unnecessary, and what kind of things have you done that other hospitals might learn from?
Sure. Well, there are guidelines around what you should and shouldn't do, what's appropriate, what's not appropriate. There are a lot of areas of medicine where we don't have guidance necessarily, but we have consensus in some areas, and we have strict guidelines in others. And so, we started probably about a decade ago looking at our utilization data for certain types of tests and procedures in the hospital, and we all agreed as a faculty in the Department of Medicine that it didn't make a lot of sense to be getting blood draws every day. So that was one of the things we first started with, because we realized, every day when a patient's in the hospital at around 6 or 7 in the morning, sometimes earlier, sometimes a little later, there'll be a phlebotomist that comes around and they'll draw your blood and they'll send off routine chemistries and routine hematology work and maybe a couple other things.
And I do remember that from in my career, earlier on in my career, that was sort of considered standard of care. Right. Every day it was like taking a blood pressure or temperature. You were expected, as a resident or intern, I was expected to know the patient's blood counts, the blood chemistries, liver function, whatever.
Right, and many years ago, you didn't even have phlebotomists. You were the one
drawing the blood. I should say, I was the one drawing the blood.
And so
I got pretty good at it.
Right, and after days and days where the blood work didn't change, you start asking yourself, do we really need to do this every day? Not only does it add additional cost, you phlebotomize a patient.
Yeah, which means you remove so much blood,
right, that
you can make them anemic.
That they actually at some point may need a blood transfusion, which has its own issues surrounding it. But also it's painful and it's disruptive. So if somebody's asleep, waking them up to get blood, or sticking somebody with a needle and having their arm be black and blue, so that by the time you're done with a 4, 5, 6 day hospitalization, your arm is all marked up. It's truly unpleasant, and so we made a conscious effort to try to cut back on it, and again, giving people permission not to send the test. So me as the attending saying to my resident, it's okay if you don't get bloods after the first day or the second day or the third day. They've had stable blood work. We know what's going on. There's not a lot of value here. Let's take a day off. Okay? Let's take another day off. So that by the time you get to the end of the process, maybe you've been able to reduce it by 10%, 20%, even 30%, and you haven't really lost anything.
Can I ask, do you miss things by doing that?
Very, very rarely, because again, when you think about, there's nothing magical about getting it every day. You can make the argument, maybe I should get it twice a day, maybe I should get it every other day. So there really isn't anything magical. It's the habit that we had gotten into, so that a resident expected on rounds to actually have those results, as you said, right? When
Yeah,
you
as
were
I said, it
training.
was a mark of honor, and throwing back to a different era in medicine, but it was a mark of honor to have all the lab work available. I just, even going back, just a story, when I was interviewing for internship, I remember going to a very prestigious internship interviewing at a place in the South, in North Carolina. And there was an arcane test called an LE prep for the patients, and the residents were doing them themselves on the night of admission so that they could have them on rounds for the following morning.
Right.
And it was sort of silly. First of all, it wasn't a standardized test. You didn't. The resident doing it was not necessarily the right person to be doing it.
Sure.
And it didn't change. It didn't have to be done with that urgency.
Sure. What really helped us was that there are groups like what's now called the Lown Institute that gave us not the award, but basically provided this ranking and this analysis for us, where we ranked #1 in the state, which we're very proud of.
And you should be.
They started something called the Right Care Alliance years ago, and the ABIM, the American Board of Internal Medicine, really initiated what's called the Choosing Wisely campaign. And so what the ABIM did, interestingly, is they wanted each discipline, whether it's internal medicine, vascular surgery, psychiatry, pediatrics, and the specialty areas, 5 things that you think are low yield that you can stop doing, or that, not that you should never do, because there's never and never, but 5 things that you really need to focus on that you should really stop doing. And I think that gave us a little bit of support to go out and say, look, we really believe in this. We really believe in being critical thinkers about what needs to be done and what doesn't need to be done. And there are just a lot of examples of things that have been done in medicine that really don't need to be done. I remember being an intern and a young resident, and at that time, women who were in their 60s, 70s, and 80s almost routinely came into the hospital. They almost routinely had a hysterectomy. It was commonplace. And now you never see it. And you have to ask yourself, what changed? And what changed is the data aren't there to support doing it for the indications that were being done. And so they stopped doing it. Our OBGYN colleagues.
And maybe you can say a little bit about that, because there's so much discussion of science in the media right now.
Sure.
It relates to COVID, but the science of medicine, we're still accumulating an awful lot about basic stuff that we've done over the years.
Sure.
Can you say a few words to that?
Sure. What we tend to do in medicine, what I've seen is we tend to obsess about the very, very small number of studies that, relatively speaking, or the small amount of knowledge that we have, and we kind of don't focus as much on the vast unknown, right? So we look at the cardiac studies, or at the neurology studies, or the hematology, oncology studies, and we think we understand everything. And in point of fact, we actually understand very little of the total that's out there.
It's funny that you say that. I just read the New England Journal yesterday, and there's an article there looking at the dose of aspirin for cardiovascular and cerebrovascular disease.
This is the comparative effect.
Comparative of 81 versus 325
We've been talking about this for like 30 or 40 years.
That's the point I was going to make.
Right.
This has been my whole career.
Right.
We've been giving aspirin for this, and
we're still talking about it.
now we're finally studying whether or not, and actually that study wasn't even definitive in and of itself, but it was. I had to smile, because that's an example of a big thing that we still don't know exactly the right answer.
Right, and we're still studying vitamin D and the correct dosages.
Yes.
And the efficacy of vitamin D, and we joke about it.
Oh, so the issue of what's the right blood pressure at different ages, we're still struggling with that.
There's a lot that we don't know, and a lot of the ways that a lot of these studies are done, they may be done only on men, or they may only be done on a certain type of man, like a Caucasian man. So we have subgroups of folks who, African Americans and folks who are Latinos, where we don't know whether or not, say, aspirin is as effective in one group versus another, or are there differences, or maybe there's a better drug. And so, we're just digging into a lot of that. And so medicine is evolving. And so what you have today in 2021 may be very different in 2030. And it's not that anybody is trying to mislead anybody. It's just that this is the best information we have at the moment, but the information is going to evolve, and it's going to be potentially different in the future.
And I think people have seen that a little bit with COVID, and how
Oh.
how what's right
Yeah.
changes over time, because science is not one study generally doesn't give you a black or white answer.
Right. I mean, COVID really just accelerated that, but really underscored it. Over the course of about a year, we went from, knowing almost nothing, from 0 to 120 miles an hour. And we were able to see it playing out over the course of the first wave that we saw really in March, April, and May, and how different things were by the time we got to the following fall. So we got a little bit of a break in the summer, but by the following fall, we really changed a lot of our practices.
And it's interesting, it doesn't mean that things were wrong, it's that information evolves.
Right.
And so I think people may be frustrated that science is really an evolution of what is true, not an absolute of what is true.
And I will say that, during COVID, there was a sense of desperation, not only among the public, but among healthcare providers, of trying to figure out what the right way to do this and treat this disease was and is. And so, one of the things we did early on was we were very aggressive with anticoagulation. We wanted everybody who was sick, who were sick enough to be in the hospital, to be on blood thinners, and not just prophylactic doses, but treatment doses, so intense, and with that comes bleeding. And so we saw patients who came in who we thought we were doing the right thing for them that wound up having bleeding complications, and that's devastating as a practitioner, because the first thing you're told is really do no harm, and you feel like this is a decision that I made that led to an adverse outcome.
And going back to sort of non-COVID medicine and unnecessary testing, I know that one of the problems that we have as a profession is disseminating new information into the practice situation.
Sure.
Something will be discovered that this is not a useful test.
Yeah.
Let's say a chest X-ray for screening for lung cancer. And yet, in practice, a lot of people continue to do that even for years. Why do you think there's such a lag between the development of knowledge and its application in the field, and how did you overcome that?
So we tend to anchor, right? I mean, one of the things that we do is we kind of get fixed in our ways, and we're, as physicians and practitioners, we're as guilty as anybody, right? We get into habits, and this is how we do things, and we're not always as agreeable towards change as maybe we should be. We took the angle of let's try to build the skills in some of these physicians when they're developing. And underscore that medicine is evolving, that throughout the course of your career you're going to constantly need to learn. That learning doesn't end when you walk out of the hospital and you go into your practice, or you take your first job or your second job or your fifth job. You're going to continuously be required to read the literature and understand what's most up to date, and then make modifications to how you do
Also,
things.
you want to say, we got about a minute left, the use of a hospice program, because I think that gave you some control of the inpatient care system.
Sure. So we have like a lot of hospitals, most of our patients that when they come into the hospital, at least in the medical service, are on the hospitalist service. And so that's a defined group of about 20 to 25 practicing clinicians. And so it's easy to kind of get your arms around that.
And they report to you.
Right. It's easier to get your arms around that than it is hundreds of practicing clinicians on your medical staff. And so you can really affect change. And then we had our residents that we would teach to. And with that, obviously, it's different if you have to teach somebody about it than if you just sort of talk about it. And so we set up a curriculum, and all of our attending physicians that are involved with the teaching service lecture to our residents, and we engage in conversation and dialogue, and we challenge each other on a day-to-day basis. And I think that's a highly functional environment, and I think it really has emphasized some of the work that we've tried to do.
Do you have any sense of how much we reduce testing, unnecessary testing, versus average, or versus the worst in the state or the country? Just I don't know where they fit on the scale.
Yeah, I don't have a great sense. And again, any study like the study that's been done by the Lown Institute, they look at a certain number of tests, and so it's not the full spectrum of everything that we do. It's just sort of a snapshot.
So they pick some representative
right.
tests to see how often we're doing those.
Right.
Right.
But we know that the variability can be 2 to 3 or 4-fold.
Yeah. It's really, again, striking how much one can reduce testing if you pay some attention to it,
Sure.
and you're given permission to do so.
Yep.
And we didn't even have a chance to discuss the medical legal aspects.
Oh.
Well, we'll save that for another day.
Another day.
Unfortunately, we have run out of time. I want to thank my guest today, a dear friend, Dr. Jason Orlinick, for joining me on Health Talk, and thank you for watching. Please share your questions and comments with us at healthtalk@newvancehealth.org. We'd love to hear from you. Take care.